The final presentation, titled, "Should CGRP antagonists be first line for migraine treatment?" will be debated by Dr. Andrew Charles, who will be debating the yes side, and Dr. Elizabeth Loader, who will be debating the no side. You know the drill. Let's see where the audience stands before we hear the speaker's thoughts. The question is, should CGRP antagonists be first line for migraine treatment? Yes or no? Dr. Charles is a professor of neurology and the Meyer Renee Luskin Chair in Migraine and Headache Studies at the UCLA School of Medicine. He is director of the UCLA Goldberg Migraine Program and is the immediate past president of the American Headache Society. Dr. Loader is a professor of neurology at Harvard Medical School and the vice chair for academic affairs in the Department of Neurology at the Brigham and Women's Hospital. She is also the head of the British Medical Journal. Please welcome Dr. Charles and Dr. Loader.
Well, thanks very much. It's a true honor to be here speaking at the American Academy of Neurology. It's also a true honor to be sharing the stage with Professor Loader, whose work in headache medicine I've admired for decades. I won't say how many decades, but let's just say we've both been at this for quite a while. I'm also honored to be here on behalf of my colleagues at UCLA up the road. It's a privilege to be able to work with this exceptionally talented group of people. Here are my disclosures. I'm going to skip quickly through those. You can see them in the program. I'll start with some background that I think Professor Loader will agree with. I hope so. Migraine is by far the most common neurological disorder, and very consistently, I'm getting advanced here. If we can go back. There we go. It comes in at number 2 on the list of time spent disabled of all disorders on the planet. So this is an exceptionally common disorder and really is a major public health issue that in general in the past has been under-recognized. It's also very important to understand migraine as not simply headache, but rather as a remarkably complex neurological event that can produce a broad constellation of symptoms that can occur before, during, or after headache. And so it's important to think about when we think about clinical trials for migraine, are they really capturing the totality of the symptoms that are going on as part of a migraine attack? And now with functional imaging studies, we have a window into pathophysiology where we can visualize regions of the brain that are activated corresponding with the different symptoms of migraine. Okay, so now for the part that may get a little bit spicy. So the previous first-line therapies for episodic migraine prevention, and sorry for my use of air quotes. Ordinarily, I don't like people using air quotes, but here I feel compelled to do it. So here are our first-line therapies, and if you look at the list, it doesn't take a headache expert to recognize that none of these therapies were developed specifically for migraine. We have antihypertensives, anti-seizure medicines, beta blockers, and so forth, but the evidence for these, apart from topiramate, is remarkably weak. The tolerability and safety for these therapies is in many cases very poor. And remarkably, about half of the medications that are considered first line for migraine are not FDA approved for that indication. So I'd like to think about, for what other disorder is that the case, that we're recommending therapies that are not FDA approved for the indication. Just pointing out some safety issues. So the World Health Organization has recommended that valproic acid, sodium valproate, should not be prescribed to women and girls of childbearing potential because of the high risk of birth defects and developmental disorders. So this is one of the first-line therapies that is among the recommendations. Even topiramate, now in the UK, there are guidelines that suggest that new pregnancy prevention measures should be required, and that topiramate should not be prescribed to women and girls unless requirements of a fairly rigorous pregnancy prevention program are met. So, in the face of these problematic first-line therapies, these non-specific therapies, there's been an intense effort to find migraine-specific targets for therapy. And I'm pleased to report that these efforts have been quite successful, and particularly in regards to neuropeptides, and the topic of discussion today is CGRP, calcitonin gene-related peptide. So Peter Goadsby and Lars Edvinsson showed now about 3 decades ago that CGRP is released during a migraine attack. Blood levels of CGRP increase during migraine and fall to normal with effective treatment of migraine. It was subsequently shown that in chronic migraine, meaning migraine more than 15 days per month, CGRP levels are persistently elevated. Now, other studies show that if you give CGRP to a migraine patient, it will provoke a migraine attack, which shows that it's not simply a correlation, but it's a causative factor within a migraine attack. And then were developed small molecule CGRP receptor antagonists, the so-called GPANs, and finally antibodies to CGRP or its receptor that are used as preventive therapies for migraine. So a really solid foundation of evidence for a primary role for CGRP in migraine and for targeting CGRP with specific therapies. Now we have 6 different therapies targeting CGRP for the prevention of migraine. So we have the monoclonal antibodies, including those listed here, and the GPANs. And these therapies have been truly transformational in our ability to change the lives of migraine patients. What's the evidence? Well, tens of thousands of patients have been studied in randomized, placebo-controlled clinical trials for CGRP targeting therapies, compared with tens for some of the other first-line therapies. There have been a remarkable number also of quote-unquote real-world studies of CGRP targeting therapies worldwide. And these have all shown highly consistent efficacy, tolerability, and safety across multiple clinical trials and real-world studies from all over the world. Multiple spheres of evidence have been developed that did not exist for other therapies, including responder rates, efficacy in patients who failed multiple other previous preventive therapies, and also efficacy in patients with medication overuse. So here's a screenshot of a PubMed search for real-world CGRP migraine, and it yields 231 results. So this is an indication of the extensive evidence from around the world. This led us, as the American Headache Society, to develop these position statement for migraine prevention, or I should say specifically migraine prevention, including both episodic and chronic migraine. And I will say that this came about because our members were clamoring for us to change the guidelines that we had put out previously. So I encourage you to look at this. This paper summarizes in much more detail what I'm discussing here today. Just a quick look at some of the data. So this is a study of atogepant, and what's represented here is responder rates. And what's remarkable is that 50% of people on 60 milligrams of atogepant had a greater than 75% reduction of mean migraine days. And if you look at the 100% responder rates, 28% of people had a 100% reduction in weeks 9 through 12 of the study. This is really quite remarkable. Here's another important study. This is a head-to-head study comparing Arenyumab versus topiramate, the therapy for which, the first-line therapy for which there is the most evidence. And the primary endpoint of this study was the percentage of patients who discontinued the medication due to adverse effects. And what you can see here is at 24 weeks, nearly 40% of patients on topiramate had discontinued the treatment compared to a roughly 10% of Arenyumab patients. And these results echo significant real-world data suggesting that for the traditional first-line therapies, less than 20% of patients who you prescribe them to are still taking them a year after you're starting them. And so this begs the question, if a patient is not going to stay on a therapy that you prescribe, what's the point? Arenyumab also beat topiramate with not just the primary endpoint, which was 50% reduction from baseline in migraine days per month, but in multiple other secondary endpoints. So I'm sure we'll talk about cost. We wouldn't even be having this debate, I don't think, if it weren't for cost. And I would urge you to consider not simply the cost of the medication, which is certainly high, and we must advocate for lower costs for treatments for all neurological therapies, but we must also consider the cost to patients, to the healthcare systems, to employers of poorly treated migraine or poorly tolerated migraine therapies. So in summary, there's a remarkable volume and quality of evidence for the efficacy, tolerability, and safety of CGRP targeting therapies for prevention of migraine. The evidence that exists vastly outweighs that for all other quote-unquote first-line therapies for migraine. Half of the therapies that are recommended currently as first-line therapies do not have FDA approval for migraine treatment. Valproate and topiramate in particular have serious, significant tolerability and safety issues. The cost of the medication is of course an issue, but what about the cost to the patients? And I would argue that failure to recognize CGRP targeting therapies as first line for migraine prevention is dismissive of the extraordinary advances in the basic and clinical science of headache medicine, and it denigrates the disability caused by the most common neurological disorder. Thanks.
Good morning, everyone, and I too am very honored to share the stage with my longtime friend and colleague, Dr. Andrew Charles. I'm also very grateful to the organizers for inviting me to this debate, and of course I've been asked to take the con side on the question, should CGRP antagonists be first line for migraine? I have no relevant financial connections with any drug or device manufacturers. I do get salary support from the British Medical Journal paid to my institution. So let's start by thinking about what is meant by that phrase, first line. And here Dr. Charles and I might disagree. It's true that there are many things that are touted as first-line treatments for disorders, but when one looks to see what the definition of first line is according to the NIH, the World Health Organization, and other bodies that issue recommendations about the order and sequence of drugs, most of them are defining it as a single drug or drug class, the preferred, the standard first choice. And they go beyond that to say that it should be the first choice for newcomers, not all comers, not that patient walking into your office who's tried everything else, but the patient who has not previously received treatment for a disorder. And when we consider this debate question from that perspective, I think it's easy to see why CGRP antagonists are not first line for migraine. They're not the preferred or standard choice or the first choice. And I have 6 arguments, any one of which should convince you, any combination of which should convince you, But taken as a whole, I think they really do refute the idea that these drugs are transformational or first line. The first argument has to do with efficacy, and I don't think it's dismissive or denigrating to say that although these drugs are clearly more effective than placebo, and it's wonderful to have new choices, every new drug picks up a patient population that has not previously benefited from treatment. So we certainly don't disagree that it's nice to have new choices. But you'll see from a wide variety of meta-analyses and even some real-world data out there that it's kind of difficult to make the argument that these treatments as a whole, the biologics, the antibodies, or the small molecule CGRP antagonists are substantially better or more effective than the alternative treatments. Other treatments similarly are quite tolerable. I think the safety argument is not one that the CGRP medications can win at this point, and I'll tell you more about that later. Finally, the money. Yes, it is an issue, but I disagree that we wouldn't be having this debate if the treatments were simply less costly. I think there are other reasons that they're not first line, and those are very convincing. There are opportunity costs that are partly related to the cost of medication, but also to other things that I'll tell you about. And finally, I think the most potent argument, and the one that is the argument of the future, is the inflexible algorithm saying that a drug or a class of drugs are first line for everybody. That's just not tenable anymore, now that we have biomarkers and other more sophisticated ways of identifying people who might be appropriate for medications. So here are the new medications, and as I was flying out here on JetBlue, I actually saw an advertisement on the screen in front of me for one of the new CGRP antagonists. So are these really the next best thing to sliced bread? Are they transformational? Well, with all due respect to Dr. Charles, I don't think so. Now, comparable or better efficacy. Certainly, there are treatments that have comparable or better efficacy than the CGRP antagonists when it comes to preventive treatment. This is especially true for abortive treatment. Remember that three of the small molecule CGRP antagonists can also be used to treat individual attacks of migraine, and there the evidence really, I don't think, supports the idea that they're first line. Now, here is the result of a meta-analysis that was done to compare several of the CGRP monoclonal antibodies with existing FDA-approved and in some cases non-FDA-approved treatments like amitriptyline with migraine, looking at both monthly migraine days and 50% responders. And I think you'll see in bold the statistically significant results really don't show a tremendous advantage in comparison to these other treatment alternatives for the CGRP monoclonal antibodies. This is pretty lackluster, I think, if you're trying to make a case for superiority on the basis of efficacy. This is also true when we look at chronic migraine patients, traditionally considered to be more difficult to treat. Again, not showing a substantial efficacy difference. Now, many meta-analyses leave out some non-FDA approved treatments that are very tolerable and also quite efficacious for migraine prevention, namely the angiotensin-converting enzymes, the angiotensin receptor blockers, and many analyses find it convenient to leave out onabotulinum toxin type A, which likewise is quite tolerable. I implore you to think about the totality of evidence and not to dismiss older or non-FDA approved classes of medications. Dr. Charles asked, in what other situation do we have many treatments that are not FDA approved? Well, pediatric practice, for example, is almost entirely bereft of treatments that are FDA approved for reasons that are clear, and this is true in the migraine field as well. So here's a meta-analysis by Jackson et al. Showing us that there are a lot of other medications that have reasonable evidence of efficacy. There are many drugs that have good evidence supporting efficacy. What about the GPANTs? Well, with my colleague from Denmark, Per Feld Hansen, a couple of years ago, I wrote an article called The Emperor's New GPANTs. suggesting that the evidence of clinically meaningful benefit for this group of treatments was really quite poor. And here we were looking at abortive treatment, looking at the therapeutic gain over placebo, showing that the new CGRP antagonists, when used abortively, really don't have very impressive results. You can see the therapeutic gain for anti-inflammatories and triptans is likewise quite impressive. Now, there was recently a meta-analysis published in the BMJ looking at the same question, also showing that some of the older triptans perform extremely well and much better than the new GPANTs. The authors concluded that the 4 triptans were more efficacious than the recently marketed drugs lasmiditan, rimegepant, and ubrogepant, which based on our results show efficacy that is comparable to acetaminophen and most NSAIDs. Well, what about tolerability? This is often trotted out as the great reason to prescribe these calcitonin-related peptide antagonists. I don't think they necessarily win there either, especially when you consider other tolerable medications and treatments, such as onabotulinum toxin A and some of the anti-angiotensin receptor blockers. Clinical experience shows, these are the results of a study done at our clinic, one of those 231 real-world evidence studies, which, by the way, shows some mixed results. And we found when Aremumab first came out that about 1/3 of patients who'd been prescribed it planned to quit. About half of them because of lack of efficacy, but 1/3 because of side effects. So real-world evidence where we are not taking people who don't have comorbidities like clinical trials do, where we are not cherry-picking the treatment-naive patients, don't show such wonderful results. And finally, if you're interested, it's very fun to peruse websites like drugs.com, where patients, people who've taken these medications will rate them. And you can see, this is not a complete list, but ranking them by the overall rating, you can see that some of the CGRP antagonists do appear down towards the bottom there, but treatments that some people think are poorly tolerated are actually rated quite highly by patients who presumably are making their own determination about the combination of efficacy and tolerability. They're not researchers cherry-picking the efficacy and tolerability outcomes that they think matter to patients. They're patients talking about what matters to them. Safety is not a winning argument either, my friend over there. CGRP does a lot of things. Now, how likely is it that treatments that effectively wipe out or hobble the actions of CGRP in the body are not going to do something else we don't want them to do? In other words, have off-target effects in the case of the antibodies. We just don't know. And furthermore, it's a little too soon to say. There are some small reassuring studies out there about vascular safety, but they're tiny. 89 patients here in this study looking at people with known heart disease, a subgroup analysis from a pivotal trial. I mean, come on. We all know, too, that post-marketing safety studies leave a huge amount to be desired and often are not completed despite FDA requirements that they should be. This is the biggest safety argument. Who is it that comes in seeking treatment for migraine? It is women of childbearing age. We do not know enough about the safety of CGRP antagonists in pregnancy. Let me repeat that. We do not know enough. It takes a long time to amass the large numbers needed to identify whether there is a signal, and of course, some of the outcomes depend on the stage of pregnancy at which exposure occurs. We had one unintended pregnancy in our clinic study over a 6-month period, about a 0.6% chance. So that's not small when you multiply by the number of people who need migraine treatment. So safety, I think, is not assured with these medications. And here's a timeline of how long it takes after the introduction of a new medicine to see some of these safety signals. It's not a couple years later. Money, I think this speaks for itself. These drugs are hideously expensive, and it is very hard, I think, to defend that, especially when you think about the efficacy of some of these things. The value proposition isn't there, and that leads to you, be my guest, fill out as many prior auths as you like for all of these treatments, but it creates a lot of opportunity costs. Every prior auth form you're filling out would be time that you could spend with patients who might benefit from other things that don't require that level of justification. And finally, let me suggest that inflexible algorithms are simply not defensible. Every single drug is a first-line drug and a great drug for someone, and no single drug or class of drugs is a first-line drug for everyone. That's not what the future holds for migraine treatment or for treatment of any other neurologic illness. There are super responders to every single treatment out there, and I think that this is not a transformational class of treatments. It's wonderful to have more options, but they simply aren't at this point first line for migraine. Thank you for your attention.
Thank you for those comments. And I will have to say that I completely agree with you about the algorithmic approach. And to be very clear, we're not suggesting that CGRP targeting therapies should be the first-line option, only that they should be a first-line option, and that we should individualize treatment for every patient, and of course treat based on comorbidities when they exist. And so that, I just need to make that clear, is we're not suggesting that CGRP targeting therapies are the first-line option. I don't know if I can come back to my slides. If not, okay. Right. Let me go back. So I also want to put up this slightly creepy AI-generated image of smiling people to illustrate the point that I have heard these words more in the last 5 years than in my entire 30 years of treating migraine patients. And those words are, my life has changed. And the reason these therapies are life-changing is because of their efficacy, their tolerability, their safety. And so this is real-world experience that we hear day in and day out. I mean, when's the last time you heard somebody that you've started on valproate say their life has changed, except maybe that they've gained weight and they now have tremor and hair loss? So this is really this is part of why we talk about these as transformational therapies. What about the acute therapies? Well, I completely agree with you as well that there's not nearly as significant evidence supporting these as acute therapies. However, there certainly may be patients for whom you would consider them as first line, including those with vascular disease, sensitivity to adverse effects. But here's another important point. If you're going to try an acute therapy with a patient, the stakes aren't really that high. You have the opportunity to try an acute therapy multiple times and see whether or not it works, and then decide whether to move on to a different therapy. It's very different with preventive therapy, where you basically commit somebody to taking the therapy for 3 months at least, or until they have intolerable side effects. And so if you then say you need to try more than one, then you're basically up to 6 months of trying a therapy before getting to the therapy that you really wanted to put the patient on in the first place. And so I think that sort of, when you talk about opportunity costs, many patients, if you put them on a poorly tolerated or ineffective preventive therapy, will give up on preventive therapies. And that's a real lost opportunity for these individuals. I would say another point about these therapies is, again, that they have been shown in multiple placebo-controlled trials to be more effective in patients than that have tried multiple previous therapies. And so while we only have one head-to-head study, which is the arenyumab versus topiramate, by implication, if you have multiple studies showing that the therapies work even in patients who have previously failed 3 or 4 or 5 preventive therapies, which are very common in our headache practices, that's an implication that these therapies are more effective. And granted, it's not the traditional head-to-head study, but this is the experience that we have in our clinic that indicates to us that indeed these therapies are more effective. One final point regarding the meta-analyses. and I alluded to this earlier, is that comparing current clinical trials to clinical trials done 30 years ago for some of the previous therapies is simply not valid, because the definitions of migraine are different, the endpoints are different, the placebo rates have changed with time, and so the typical meta-analysis approach cannot be used in this kind of setting. So finally, I'll just go back to this nice image here and say, make a case that we really need to be able to offer our patients as first line these life-changing therapies. Thanks.
Well, nice try, my friend. And with all due respect to you and Khloe Kardashian and Serena Williams and Ryan Murphy and Lady Gaga, and all of the people out there trying to convince us to use these expensive, not all that effective medications for which safety is not yet assured, let me tell you, that's not the whole story. There's a lot more to it. Dr. Charles mentioned the meta-analyses and suggested that it isn't wise to compare recent trials with older trials because of the many methodologic shortcomings of older trials, and to some extent that's true, but he also said there's only one head-to-head trial. Now, whose fault is that? Why is that? Why don't the manufacturers, if they're trying to get us to use these extremely expensive drugs and touting the value proposition, why don't they show us the head-to-head evidence? And in fact, we have good recent trials for topiramate. We have good recent trials for onabotulinum toxin type A. So I disagree that the evidence is all poorly done and doesn't merit our attention. And I think, too, that many of the trials done for some of the ARBs and angiotensin-converting enzymes are of reasonable quality. Now, when you do a meta-analysis, you have to make a lot of decisions, and so it's important to look at what those decisions were. The devil is in the details, and here's one that concludes that the CGRP antibodies are great, but they didn't include onabotulinum toxin, and they didn't include ARBs. Why might that be? Well, I don't know, but look at the list of competing interests there and see if you can identify any themes. Is it right that the people who are generating the evidence are also those judging the evidence and writing the meta-analyses and the guidelines and things like that? I'm also a former president of the American Headache Society, and I happen to know that the AHS gets a lot of money from these companies. So it has to be thought of in light of those competing interests when you see recommendations to use medications first line or not. People who have no competing interests and ties often sift through the same evidence and come to very different conclusions, dueling meta-analyses. Here's one that was undertaken by people who have no real ties to the manufacturers but do have the expertise to do meta-analyses, and they come to a very different conclusion. And I present here first their competing interest statements, which do not include a long list of pharmaceutical companies, and here is their conclusion. All of these medications are more effective than placebo. There's no question about that, and as I've said, it's wonderful to have them. But the absolute differences in number of migraine days and responder rates are, at best, modest. That's the word they choose. Don't just trust me, though. The FDA as well has sent out a warning letter to one of the companies about an advertisement. They don't send these out a lot. There were only 2 issued last year, these 528 letters, and one was to the manufacturer of one of these small molecule medications saying that a commercial with Serena Williams actually was not accurate in the way it appeared to depict the efficacy of the medication. It showed her migraine instantly going away, when in reality they commented it could take time and multiple doses. Adverse events. Let me list the adverse events that didn't show up so much in clinical trials, but do in clinical practice. Constipation is a serious problem, including obstipation, sometimes leading to serious outcomes for patients. Here again, the rating by patients who presumably are comparing efficacy and tolerability. Yes, lots of people come into my office and say their lives have changed, but it's not in relation to a single drug class. And actually, the group of medicines for which that is the most true are the triptans. Patients will gush about triptans, especially those who were around before they were available and then had the chance to try triptans. User reviews for Arenumab are not all that great. Here at drugs.com, they give it a total of 4.9 on a 0 to 10 point scale, and topiramate is given 5.9. Now, this isn't the most robust evidence, but it is real-world evidence, and it does show that every drug has its aficionados. Safety, we just don't have good enough evidence on safety, and even the people who write some of these papers agree. We need more pharmacovigilance studies. They say to date there aren't any signals of pregnancy problems or teratogenicity, but we really don't have the evidence necessary to say that. Furthermore, the CGRP antibodies stick around for a long time, so if you're in trouble for a long time. And that's why these drugs are new. Finally, the cost and the value proposition are not there. These drugs are unattainable for many. It's a time sink for doctors, and it creates inequity in the way the benefits of these new treatments are distributed. And finally, the future is finding the right drug for a particular patient, and this will depend on biomarkers and polygenic risk scores and other more sophisticated approaches to finding what's first line for a particular patient. Thank you for your attention.